So Dr. Helen Marr is a consultant haematologist working at the Freeman Hospital here in Newcastle, and she trained in the University of Nottingham and qualified in 2002. Worked in Christchurch, New Zealand from 2006 to 2008, and was awarded her FRC path in 2012 and awarded a PhD in the role of CD38 in the IRF4 transcription of CLL in 2015. She was appointed a consultant in December 2017 and is chair of the Regional North of Tyne Haematology multidisciplinary team. And she's well known to us at CLL Support as part of the UK CLL Forum exec team, and has spoken at webinars for us during the pandemic.
Thank you so much for the introduction, John, and for inviting me to come and speak here. I have to say, I'm genuinely really privileged and quite humbled to come and be asked to come and speak here. Liam's talk really choked me up, quite honestly, it really did. And Catherine as well, who knows Liam well through all of his treatment as well. So I really do feel quite privileged to be asked to come and speak. These are my disclosures that we always need to reveal when we're coming to speak at a talk such as this. And I'm going to start by saying that, honestly, a patient group is a tough crowd. So I'd be much more comfortable speaking to a group of consultants, you know, at the British Society of Haematology Forum or something, than speaking to a patient group. It honestly gives me the fear slightly. And that's because you come with the hardest questions, without a doubt. But the other thing is that I know there'll be a real mixture of people in the room here. Some of you, and this was my image for Googling rabbit in the headlights, okay? So some of you might have been quite recently diagnosed and you're still absolutely like, what the hell has just been chucked into my life? What is going on? How the hell do I get my head around this? And some of you may have been living with CLL for 20 years. You might have gone through all manner of lines of treatment, you might have met your consultant a million times, and you are experts in CLL and in your condition. So I'm aware that I'm speaking to a really mixed group. So I hope that the people who already have a lot of knowledge about CLL, I hope I can still share some interesting information with you. I'm sorry if it's all stuff you already know. I guess I've really started with the basics in the interest of people who are still absolutely getting their head around this for the first time ever. So I'm doing two talks, one before and one after lunch, and we've obviously got Gavin in between, who's an absolutely brilliant speaker. In this first talk, I'm going to focus really on the basics of what is CLL, and a bit about staging, and a little bit about that obvious question that has already been brought up many times: why don't we treat all patients? I'm going to very briefly at the end of this first talk touch on some of the genetic tests, but Gavin's going to go talk about that in much more detail. And then in the second talk this afternoon, talk more about what CLL treatments we have available and how we make those decisions. So starting first of all, and I've said I'm going to be basic and then I'm going to throw that picture up, sorry. So what is CLL? So I'm just going to use my little cursor if I can, if you see here. So this is just a diagram of hematopoiesis, and all that means is making blood cells. So blood cells are made in your bone marrow, which is the liquidy stuff in your hip bones. Your bone marrow makes your blood cells, and then your blood cells travel around your body in your blood, okay? So this is just a diagram of hemapoiesis, making blood cells in your bone marrow. So what is CLL? The word leukemia, leuc just means white, so we're just talking about white blood cells, and emia means blood. So essentially we're just talking about too many of a type of white blood cell in your blood. The chronic bit of it means that this is a type of leukemia that can develop over a period of weeks, months, even years, not something that just comes up very quickly over a matter of days and weeks. So we also have acute leukemias which can develop over days or weeks. Chronic leukemia is a whole different ballgame, something that can be there for months or even years, and sometimes people don't even know about it. And the lymphocytic bit of it refers to which type of blood cell is affected by the leukemia. So just looking at this again in slightly more detail. So same diagram again with our blood making. We start here with this bit at the top right here, essentially sort of grown-up parent blood cell. This is your stem cell, which is going to develop into all the other types of blood cells that you can make. So this is hanging out in your bone marrow and going to develop into all of the other types of mature blood cells. All of these ones, so the majority of the types of blood cell you're making, we would call myeloid blood cells, and we'll come back to those in a second. When we're talking about CLL, we're talking about these lymphoid cells. So this little group of blood cells that your bone marrow is making, called lymphocytes. Lymphocytes are a very important part of the immune system. You have T cell lymphocytes and B cell lymphocytes. Lymphocytes are an important part of the immune system, particularly for helping to fight viral infections, but they have quite a range of different roles. And when we're talking about CLL, we're particularly talking about a leukemia affecting the B cell type of lymphocyte. Okay? Coming back to all these other blood cells, because you will hear about those quite possibly. If you're talking about CLL or reading about it, or if you're going through treatment, you'll hear about us talking about things to do with that. So in the other bits of your blood cell, in the other bits of the blood making, so these cells aren't affected by the leukemia. These are normal, healthy blood cells that your bone marrow needs to be making. So we've got red blood cells at the bottom, also known as erythrocytes, but we just call them red blood cells. And they carry hemoglobin. So Beth mentioned her HB, her hemoglobin level. That's in your red blood cells. It attaches to oxygen and you need it to give you energy. So if you have low red blood cell levels, we call that anemia. Your platelets, another important type of blood cell that you will see possibly in your clinic letters or, on your list of blood cell results if you're in clinic. Your platelets are needed for your blood to clot normally. So if you haven't got enough platelets, well, if you've just got not quite enough platelets, if it's quite mild or moderately low level, then actually you can not have any symptoms at all. It doesn't cause you any bother at all. You actually have to get down to really quite a low platelet number for it to cause any symptoms. And then those symptoms would tend to be things like bleeding or bruising, because you haven't got enough platelets for your blood to clot normally. So then if you cut yourself, you bleed for longer, or you might even have bruising coming up for no reason when you haven't bashed yourself. And finally, neutrophils, certainly people who've been through chemotherapy, but also through some of our newer treatments as well, will definitely have heard about neutrophils or neutropenia. So neutrophils are another type of white blood cell, but they're a type of the myeloid white blood cell rather than the lymphocyte or lymphoid white blood cell, and they're particularly important in fighting bacterial infections. And when those levels are low, we say that they're neutropenia, and that makes you more prone to bacterial infections. So we'll kind of refer back a bit to this as we carry on through the talk. So when we're talking about CLL, CLL essentially is a clonal, which does mean cancerous, proliferation, growth, accumulation. So too many accumulating, growing, proliferating type of these B lymphocyte white blood cells. And it's because a cancer is affecting those white blood cells, and therefore they're growing and proliferating and accumulating out of control, more than we need. And it can affect the bone marrow, the blood, and the lymph glands. I think they're all, they're a system that are all connected. So this is just a picture of some bone marrow. If we were to do a bone marrow biopsy and look at a chunk of it down a microscope, we would see a picture a bit like this. This is just a chunk of bone marrow. Your bone marrow is making the blood cells, and then they go out and about, and they're in your blood. So if we take some blood and we stick it on a slide and we look at it down a microscope, this is what it looks like. And they also affect potentially your lymph glands. This is a picture of somebody's armpit with a lymph gland in it, because we have lymph glands, everybody has lymph glands in their neck, top of their shoulder blades here, under their arms, in their groin. Everybody also has lymph glands inside their chest and inside your tummy. We can't feel for those, we can't see them. The only way we can see those is with a CT scan or something similar. We can often feel lymph glands in the neck, under the arms, and in the groins. I've said here that bone marrow, blood, and lymph glands are all connected, and CLL can affect any, or just one, or two, or all of them at any one time. So there'll be people here with SLL, which I think and CLL doctors think of as very much the same thing as CLL, just with a slightly different name. It looks the same down a microscope, it's just it only hangs out in the lymph glands. We don't see it hanging out in the blood or the bone marrow. But it's the same thing, the cells look the same, they respond the same, we treat it in the same way. CLL, by definition, if we're saying you've got CLL, some of it, even if it's just a tiny level, will be in your blood. Okay? Because if it's only in your lymph glands, we call it SLL. But if there's any of it in your blood, we need to call it CLL. It's just semantics. They're not really different diseases, it's just semantics, okay? So we might find CLL only in your blood, or we might find it in your blood and in your lymph glands. If it's in your blood, it will be in your bone marrow as well, because as you remember, your blood gets made in your bone marrow and goes out and about in your bloodstream. So if it's got out into your blood, it must have been in your bone marrow to start with, okay? And I just did the little picture there of where the lymph glands are and marked if I just show you my cursor, we've got liver here on the right-hand side, spleen on the left-hand side, as well as these different lymph glands. It says cervical, which is neck, axillary, under your arms, inguinal down in your groin here, but as I said, you also have them in your chest and inside your tummy. And everybody has lymph glands. We need them to help fight infection. But if CLL cells go and hang out in your lymph glands, then those lymph glands can become enlarged. We think of the spleen as being an honorary lymph gland. It's just part of the whole same system. And the liver is also very closely connected to the lymph glands and the bone marrow and the blood, so liver can be affected as well. So, thinking of what I've told you so far, it therefore doesn't come as a surprise that how CLL can present. So people can present, be diagnosed, go to their doctor in the first place because of enlarged lymph glands that they become aware of. It's probably uncommon that people become aware of an enlarged spleen, but not impossible. If a spleen becomes very big, and I mean really big, not just slightly enlarged, people might be aware of a sort of fullness in their tummy, or I feel more full than I normally do when I'm eating and I can't finish a full meal. It's quite uncommon for that to be how people first go to their GP, but it's very common that people go because they've noticed some lymph glands that are enlarged and they go with a lump. Another way people can present is if you've got a lot of CLL in your bone marrow, and therefore those CLL cells accumulating, growing, proliferating in your bone marrow are getting in the way of making those other normal healthy blood cells, all those myeloid ones which were in that whole other section on the first picture. So if they're getting in the way of making the normal healthy red blood cells, making the normal healthy platelet cells, or the normal healthy neutrophil white blood cells that defend you against bacterial type infections, potentially you might have symptoms because one of those is low, or all of them are low, or two of them are low. So for example, a very common symptom could be anemia. Somebody becomes anemic because their red blood cell level is lower than it should be because the CLL cells are taking up the space in the bone marrow and getting in the way of making the normal healthy red blood cells. And Bethan mentioned that during her second presentation, that she was very anemic, also her platelet count went low. So her normal healthy blood cells, the bone marrow was struggling to make them, or enough of them, because the CLL cells were getting in the way. Symptoms. Symptoms are tricky, and I'm going to talk about that a little bit more on a later slide, but the classic symptoms we talk about as being symptoms caused by CLL are these B symptoms. And you may well find you often get asked about these in a clinic appointment, and there's three specific things: unexplained weight loss, daytime fevers that aren't explained, you haven't got a virus or an illness or whatever, you're just getting fevers for no reason, and drenching night sweats. And when we say drenching, because I think a lot of people sweat at night, but when we say drenching, we mean it feels like somebody has chucked 3 buckets of water over you in the bed, and you have no choice but to get out of your bed and change all of your night clothes and all of the sheet. There is no way you can sleep in that because somebody has chucked buckets of water over you. So absolutely drenching. So those are the 3 classic symptoms we talk about. But also tiredness and fatigue, without a doubt, is a symptom that a lot of patients tell us about. And I'm going to talk a little bit more about that as we go along. I've told you that lymphocytes are important in fighting viral infections, and CLL affects the B lymphocytes. So CLL definitely has an impact on people's ability to fight infections, particularly viral infections. The impact it has is definitely variable between different patients, and we know that definitely when we study the function of different people's lymphocytes who have CLL. So some people will have only a very mild impact in their viral fighting ability, and other people will have a more significant impact. So it is very variable and sort of heterogeneous between patients. But we know that CLL definitely does affect the immune system, so recurrent infections can be a way that people present. Now, Liam said he is definitely not a typical patient. As he said, the typical age of patient is around 70. That's the sort of median age of diagnosis. But we certainly have patients ranging from their 20s through to their 90s, easily. Haven't yet hit the 100 mark. I'm sure it won't be long. As Hilary said, it is more common in men than women. That's only a marginal sort of difference, but there is slightly more common in men. Interestingly, Bethan mentioned her aunt, and we don't talk about CLL as running in families. It's not something that you can inherit. If you've got CLL, this absolutely does not mean you're going to pass it down to your children or anything like that, okay? But given that any leukemia is actually not a very common cancer overall, if we compare it to breast cancer, prostate cancer, and so on, we do notice a slight increase of approximately 4 times higher chance of CLL in first-degree relatives, so parents, siblings, children. Okay, but if you think overall, the CLL or any type of leukemia is not a common cancer compared to all the other sort of cancers we think of, breast cancer, colon cancer, and so on. The most common way that patients present, and this may well apply to many of you in the room, is just coincidentally. So you go and have a blood test done for some completely other reason, or you go for your routine breast screening and somebody's done a mammogram, they said, oh, you've got a lymph node there under your arm, or some other coincidental thing. You're having a CT done of your chest to follow up because you had a pneumonia 6 months ago, whatever it is, and somebody says, oh, you've got some lymph nodes on that. That is one of the most common ways that patients present, is coincidentally having a test done for another reason. Which sort of reminds us this is a chronic condition that often people might have for months or even years without knowing about. So how do we actually make the diagnosis if the suspicion has been raised because somebody's got, they've come with a lump, or somebody's done a blood test and found that there's a high white blood cell count, what's going on? Well, very often a blood test alone is enough to make the diagnosis, and you don't need any other biopsies, because if we see if there's CLL cells in the blood, we can identify them. First of all, we can see on just a normal blood cell count, so a normal full blood count, simplest test we do in the lab, there's too many white blood cells there. What type are they? They're lymphocytes. Right. Exactly what type of lymphocytes are they? So then to do that test, we do something called either flow cytometry. It's got 3 different names. They're all the same thing. Flow cytometry, immunophenotyping, or cell surface markers. Cell surface markers is the best name for it because it does exactly what it says on the tin. It's a test that is telling you exactly what markers are on this cell's surface, because that's like that cell signature that tells us what kind of cell it is. So those markers can tell us this is a lymphoid cell and it's a mature type of lymph cell. This is chronic lymphocytic leukemia. So that's a dead simple test we can do, and we can have that result in a day. Okay. If there's nothing in your blood, and so this is really relating to somebody with SLL who's come to the clinic with a lump or bump but nothing in their blood, because obviously some people might be referred with a lump or bump and we do a blood test and we say, actually, there's too many lymphocytes there, we can make the diagnosis that way. But if there's a lump or bump and an enlarged lymph gland and there's no sign of any CLL cells in the blood, then we do have to do a lymph node biopsy to make the diagnosis. Again, it's essentially the same thing. We get the bit of the cell, a bit of the lymph node to look at down the microscope, and then we can look at that same signature on those cells to work out that they're CLL cells that we're seeing in the lymph node. It's really very rare these days that we do a bone marrow biopsy as part of diagnosis. It's very rare. But again, if, for example, you were presenting with abnormal blood counts, so you were very anemic or the other cells were low, but we weren't seeing much in the way of cells in the blood that made it obvious to us that was CLL, and there weren't any lymph nodes to biopsy, then we might do a bone marrow biopsy to say, right, is there CLL in the bone marrow here? Can we actually see it when we look at the bone marrow itself? That's really quite rare, because most likely we're going to be able to see it in the blood first anyway. Gavin's going to talk much more about the genetic tests that we can do on these samples, because similarly we can use blood, bone marrow, lymph gland to do some genetic tests on, which can be informative and helpful as well. A little bit about staging, because this is something that patients often ask me about in clinic, and to be quite honest, it's so at the back of my mind, I'm not even thinking about it. So I'm like, oh, good, I haven't even thought about your staging. And I'll explain why that is. So staging in CLL, when we talk about CLL staging, basically 2 things are important in staging. One is it affecting your normal healthy blood count? So are you anemic, low red blood cell levels? Do you have low platelets? That's one thing that impacts on what stage you are. And the other thing is, have you got enlarged lymph nodes or spleen? And if so, how many different lymph nodes are affected? Is it just your neck? Is it in other places? Where is it? Okay? And that goes together to form what stage we call you. And typically in the UK, we use the B&A staging system, and we call stage either A, B, or C, with C being the most advanced and A being the earliest. Often in the US, they use the RIE staging system, which is stage 1 to 4. But a really important word on staging. The staging systems, the B&A and RIE staging systems, which if you Google about CLL and look up staging, is most typically what you'll find, are years old. And essentially they are out of date, because they were developed in the era when our only treatment was chemotherapy. And as we've heard about already, and we're going to go on and talk about a bit more later on, we have many more new different treatments available which are not chemotherapy. Essentially, we really don't use chemotherapy anymore in CLL. So using these staging systems to give yourself an idea of prognosis. Oh my goodness me, he's pressing me with a timer. When we talk about staging systems, and it can throw people. If you look up a staging system on Google and you find this and you think, heavens to Betsy, I've just been diagnosed with something. Oh my goodness, I'm anemic and I've only got 2 to 4 years to live. This is not the case in our novel agent era. These staging systems were developed in the 1970s and the 1980s. They are essentially out of date. So I really don't even talk about staging with patients. It literally doesn't even come to my head. And people often ask about it because it's often something you hear about with other, what we call solid organ tumours, such as breast cancer, colon cancer, and so on. People hear about staging, and so they're aware that that's something important. But it's not something we think about in CLL. So at diagnosis, it's hard to predict how an individual patient's CLL will behave, and I've nicked this slide off George Follows, who's a consultant in Cambridge. So some patients' CLL will behave what we call very indolently. It's slow. Nothing happens for years and years and years, if ever. Some patients, and I'm going to put Liam in this bracket, will race away like this. And so they need treatment straight away, and we need to keep on top of this, and it doesn't behave. Of these two, our friend on the left is far more common than the spotty fella on the right. Okay, so it is far more common for CLL or SLL to behave in this slow-growing, indolent way. And there's plenty of people in this middle section, okay? So indolent or slow-growing CLL. So some patients will never need treatment in their whole lives. Okay, and that's really important and really key. And like Liam said, if you're in this watch and wait, watch and worry bracket, don't spend all that time watching and worrying. And I'm not going to tell you what to do and watch and wait because I'm not living with this. It's much more sensible that you listen to Liam and Beth and each other about this. But some people will never need treatment for this in their whole lives. And over that period of time, the leukemia cell white count may well go up, but that in itself is not an indication or requirement for treatment. And we'll talk a bit more about that as we go on. Some patients will never have symptoms which meet the criteria for starting treatment. They'll never develop low blood counts like anemia or low platelets. They'll never have problems with enlarged lymph glands. That's not to say they might not have some enlarged lymph glands, but they might just be, a few minor things which don't change and aren't bothering them. Why don't we treat all patients with CLL? For goodness sake, it's a cancer. Are we just trying to save money in the NHS? Why don't we just treat everybody? Well, this is not something we just do in the NHS. This is an international guidelines. This is an international workshop CLL guideline, and this is how we've practiced in CLL for very many years. This is the most updated international treatment guideline, but there are very specific criteria for when CLL needs treatment, and it reflects on when is the CLL actually causing a problem. So it's actually causing a problem if it's causing low blood counts, anemia, low platelets, which are causing symptoms, okay, as Bethan described, needing treatment in her second round of treatment. If you've got lymph glands, if you've got a few lymph glands you can feel, but they're not really changing, they're not bothering you, we will monitor those. We do not automatically need to treat those. If they're growing rapidly or they're bothering you, this is getting in my way, I can see it, I don't like it, or it's under my arm and it's bothering me, that is an indication for treatment. And B symptoms, so the drenching night sweats, fevers, or unexplained weight loss. Significant fatigue is mentioned in the international guideline criteria for needing treatment, and I'll talk a little bit more about that. But just going back to the white cell numbers, as I said, for some people who never need treatment in their whole lives, the white count cell number may well go up over that time. But I actually, and I say this to patients sometimes, I don't care if your white count is 500. A normal white count number is around 10 or 11. I don't care if it's 500. If you are well and you don't have problems with lymph nodes and the rest of your normal blood counts are fine, then we can just continue to monitor this. Having that many white blood cells isn't causing you a problem, and it isn't an indication for treatment. The indication in the international criteria is about rate of change. If you've gone from a white count of 200 3 months ago to 500 now, that's different. Something's changing very quickly, then we do need to think about treatment. But if this is just creeping up slowly over years and years and years, the number on its own is not an indication for treatment. And the reason we don't treat is we have very clear research studies with hundreds of patients, thousands of patients, which show that treating in the absence of these signs or symptoms does not help outcomes. And when I say outcomes, very specifically, it doesn't make people live longer. So giving treatment before patients meet these treatment criteria does not have an overall survival benefit. And I'll show you this specifically with one of my graphs, as John mentioned. So this was in the era of chemotherapy. This one on the right is in the era of novel agents. And essentially what we're looking at here is how many people are alive as time goes on, from the time of diagnosis with CLL, and either doing nothing and actively monitoring them or watching and waiting, or giving them some treatment. And regardless, in the left-hand graph, if it's chemotherapy, or in the right-hand one, if it's a novel agent, such as ibrutinib, you can see that the curves overlap. We don't make people live longer by giving them treatment. What we do is give them side effects, but we don't make them live longer. So there is no benefit to treating somebody who has no symptoms. We're not going to improve outcomes, we're just going to give side effects from treatment. And you can see here, when we compared the 5-year survival of patients treated with a placebo versus treated with ibrutinib, a novel agent in CLL, 5 years, 94% of the patients were still alive, whichever group they were in. We didn't change anything by treating them. We just gave them side effects. So active monitoring or watch and wait, and I accept that for some people it does feel like wait and worry, remains the standard of care for patients who don't meet criteria for treatment. So when you're in clinic, what we're doing essentially is assessing, is there an indication for treatment, by asking you about symptoms. Sometimes an examination for seeing if there's lymph glands. Often you'll be doing your appointments by telephone, and that's not because we can't be bothered. But in my head, what I think is, the main question is, are the lymph nodes symptomatic? That's the reason for treating you. So if I speak to you on the phone, you say, I've got a little bit of a lymph gland under my arm, which is new, then I want to see you, because I want to document how big is it now so we can compare, is it changing? If you're not aware of any lymph glands because there's no symptoms from them, they're so small you can't feel them, then that to me would not be an indication for treatment, and so that's something we just continue to monitor. The blood count bit of it, when you come to clinic and have your blood cell count done, I've put in small letters at the bottom, what is the white count doing? Because from my point of view, that's the least important bit. I'm much more interested in what are your healthy blood cell counts doing, the red blood cells, hemoglobin, the platelets, and the neutrophil white blood cells. What your lymphocyte white blood count is doing is less important. A little word on symptoms and treatment criteria, and I've got John's clock ticking in front of me here. So anemia and low blood counts. I think it's really important, if somebody starts to become anemic when we're monitoring them in clinic, we need to make sure CLL is definitely the reason for the anemia. We mustn't assume, oh my goodness, you've got CLL, now you're anemic, right, you need treatment for your CLL. Because you might be anemic for some completely other reason. You might be anemic because you've become iron deficient. You might be anemic because you've got B12 deficiency. There are many reasons. You might be anemic because you've got rheumatoid arthritis, and that can make, there are many, many different reasons why people become anemic. So it's really important we check first, we rule out other causes before jumping in with CLL treatment. Fatigue. And this kind of goes on with this bit at the bottom about patient X didn't have any symptoms when I saw him in clinic. I always keep this in mind, and particularly when I'm writing my clinic letters, because I remember somebody else, another patient from the CLL Support Association, saying, I got really annoyed when my consultant writes a letter saying, Mrs. X didn't have any symptoms when I saw her in clinic. I did have symptoms, and I told the doctor, it's just that they didn't count to the doctor because they're not B symptoms. So I'm really mindful of that, because I think there are, people do experience symptoms to do with CLL, and often when we're talking about they don't have symptoms, I guess we're talking from the point of view of, I've got my do you need treatment for your CLL brain on. But I accept that often there are symptoms. Fatigue is really difficult. I think there's a lot of reasons in this modern world why we are fatigued, and picking apart, is fatigue related to CLL or not, is really, really tricky. And I've heard some, big cheeses at international meetings saying, if fatigue is the only symptom, even though it is in the international criteria as a reason for treating CLL, if it's your only reason for treating CLL, often we don't see an improvement in fatigue after we've treated the CLL, and whether that's reflecting that actually it's sort of multifactorial and CLL wasn't the only cause of fatigue in the first place. So in terms of supportive care in patients who are being actively monitored, and this is so important, we've actually included it in the most recently updated BSH, British Society of Haematology guidelines in CLL, which have just been published very recently. So keeping fit and active, we recognise that exercise and activity, and also supporting all the sort of mental health and emotional aspects that Hilary has talked about and that Rachel's going to speak about later, is really important in patients when they're on active monitoring. The CLL Support Association, if you haven't already seen this, this is a brilliant resource because vaccinations are definitely important. We recognise, as I've said, that infections are a risk for patients with CLL, and it's really important that you're up to date with the relevant vaccinations. And there's a brilliant sort of little booklet that you can print out or use online. In terms of keeping up to date with your vaccinations, this is really key, and the CLL Support Association are brilliant keeping this updated because obviously these recommendations suddenly sometimes change from year to year. Whether or not giving CLL treatment, and I'm sorry, my title just doesn't even make sense there, but essentially what it should say is, does giving patients who have CLL who are getting recurrent infections, does it improve outcomes for them in terms of recurrent infections and other outcomes that could be measured? This is actually a subject of a future trial. So we don't actually know the answer to this question yet. So as I said, at diagnosis, it's hard to predict how a patient's CLL will behave. We do have some important prognostic markers which can give us some information about how patients are likely to respond as and when they need treatment. And sometimes we do use these results to add to our decision-making process about which treatment to use if treatment is needed. And I promised John I'm literally on to my last couple of slides because Gavin's going to go into this in much more detail. But these are some of the things you might hear about or see written down in your clinic letters. These are some of the things that we know can be important in CLL prognosis, particularly when we're thinking about treatment. So chromosomal abnormalities, bits of chromosomes either lost or gained, mutations within specific genes, and also this thing called, well, I won't even say it because I've not got enough time, but IGHV rearrangements, so IGHV mutation status. Very brief. This is the germinal centre in a lymph gland, in one of your lymph glands, in my lymph glands, in everybody's lymph glands. Your immature B lymphocyte, naive B cells, go into your germinal centre to be taught how to be a mature and useful B lymphocyte that knows how to deal with infections and do other stuff. So this is an immature B lymphocyte blood cell, and it goes and undergoes this process called IGVH mutation when it's within the lymph gland in the germinal centre. So CLL cells developing from B cells either have or haven't undergone this process when they become CLL cells. And this is what this unmutated, mutated bit means. If your CLL cell has gone through this process, it's called mutated IGHV or mutated CLL. If it hasn't, we call it unmutated. So it just sort of reflects where in that process your B cell turned into a CLL cell. Slightly more simplified, an immature B cell hasn't yet, it can recognize any sort of foreign antigen, any bug, any protein that is foreign to it. Whereas the mutated mature B cell has been trained to recognize a specific antigen. So they've just gone through a different training process. And so we can develop CLL from either those immature, unmutated or mature mutated IGHV cells. Never changes. So this isn't something we have to retest over the course of having CLL. You get tested once and it will never change. Okay, so it only needs to be tested once. In the era of chemotherapy, and here's another graph, in the era of chemotherapy, the IGHV mutation status has a very significant impact on how patients respond to treatment. So the dotted line at the top is patients with mutated IGHV, and the solid line at the bottom is unmutated IGHV. So you can see as time goes on, when patients are treated with chemotherapy, the patients who have a mutated IGHV status seem to be living longer, and their CLL is staying away for longer. This is in the era of chemotherapy, and I'm going to show you in the talk later on how things have changed in our novel treatment era. Finally, P53, you will all have heard of, well, many of you will have heard of the P53 gene. It's something you definitely come across if you're looking up information about CLL. And again, here, and we're talking again, this paper's from 2000, so we're talking very much in a chemotherapy era. That yellow line on the left is people with a problem with their P53 gene, clearly not living as long. And again, I'll show you later on some charts that show us that things have really changed in our novel treatment era. I'm going to stop there, you'll all be pleased to hear. But in summary, CLL is a cancer of lymphocyte B cells. It can present with no symptoms at all. It can be a coincidental diagnosis. Or it can present with symptoms, or all those symptoms and signs can develop over time. It does not automatically need treatment, and it's not because we're trying to save money or because we can't be bothered. It's because we know we don't actually improve outcomes if we give treatment before the treatment is needed. We just give you side effects and problems. And we're now going to hear a lot more detail about some of the genetic tests that are important when we're thinking about CLL. And I'm sorry for running over time.
But just to clarify something, your mutated status can't change, but can your deletion change? from a 13q to a 17p.
Yeah, as Helen referred, the CLL is a clonal disorder. So you grow from one cell that maybe might be IGHV unmutated. That's never going to change because that original cell, you can't go back and change that original cell. But then all of the daughter cells, let's say we call them daughter cells in that clone, are all derived from that original one. You can get additional abnormalities. So if you've got P53, then that is very likely to lead to additional abnormalities because it's not detecting DNA damage anymore. So those things can arise. So you could start off with a 13q deletion, and then you'd look again in a few years' time, and now you've acquired an 11q deletion. So we do regularly look back and then just always compare for progression.
And should we worry about that change?
Well, I'm talking about genetics here. I'm talking about P53 and IGHV. I mean, the reality is that an awful lot of the traditional significance of these deletions is now swept away by the new therapies. So an awful lot of the significance of that is less valid than it was.
I think, like you were saying before in answer to your question, so exactly as you said, in anybody, in all of us, forget CLL, in anybody, all of our cells are dividing and changing every single day, and there's genetic changes and potential genetic damage happening in all of our cells every day. Part of our immune system's job is to fight infections. Part of our immune system's job is to recognise DNA damage happening and sort it out so those cells don't become cancer cells, okay? But for some of the cells, and as you said, we're not talking about things that can be inherited or passed on, because it's not genetic changes that are happening in sperm and egg cells that then, are something that's passed on. It's genetic changes that are happening in all of our cells all the time, and our body is trying to recognise that's a problem, sort it out so that doesn't become a problem cancer cell. But if one of those changes sneaks through and does become a cancer cell, now that's a cell with a genetic change in that Gavin can detect. And similarly, CLL cells, they're going to carry on dividing just as all of the other cells are dividing, so they also have the potential to acquire new genetic changes as time goes on.
Going back to your analogy of tortoise, donkey and cheetah, are you able now, with all this information, able to tell a patient at diagnosis which one they're likely to be?
So no, the honest answer is no. So two things. Because many of our patients actually are in that tortoise category, we actually we don't go looking for a lot of these changes at the time of diagnosis because they will never be relevant, because often we're using this information to help inform treatment decisions. So we don't actually go looking for this information in an awful lot of our patients. Even if we were to go looking for it, things like IGVH status and P53 and deletion 17p, we certainly know they have an influence on treatment outcomes, so how well they respond in the era of chemotherapy to treatment. Actually, how long will you be from diagnosis to needing treatment is a bit less clear. So we can't actually, even with all that information, predict the three animal categories at the outset, which is why, in a sense, we do a lot more clinical assessment, which gives us much more information in terms of the trajectory of somebody's CLL. There's a big project that's now fully recruited that some of you may well have taken part in, called Oxplored, which Anna Shue, a haematologist in Oxford, has run, and she has collected a lot of samples from patients with CLL who didn't need treatment at the time of collecting the information, and she's looking at a whole load of genetic information in all of those patients and then collecting data about which of these patients do go on to need treatment, exactly to try and see whether we can answer some of those questions. So it's kind of an ongoing thing, but not something yet that we can answer yet.